Good morning. I thank Chandana Reddy ma'am for the invitation and local Hyderabad ISCCM chapter for conducting regular academic sessions. I hope everyone is enjoying the wonderful sessions that have been happening since morning, and I would like to congratulate entire organizing team and scientific committee for compilation of such wonderful topics. Coming to my topic, I am going to discuss for next 15 to 20 minutes about how to manage a pregnant patient and how is it going to differ from managing a non-pregnant individual. Because of significant physiological changes that happens during the pregnancy, various aspects of care will be differed, especially monitoring threshold, while positioning a pregnant individual, we need to take special precautions, and we need to follow a special precautions while conducting a specific procedures. And almost all the patients admits to the ICU because of diseases which are specific to the pregnancy. Even while doing cardiopulmonary resuscitation, it's going to be slightly different from resuscitating a non-pregnant individual. Coming to physiological changes, unless we understand the physiological changes that happens in the pregnancy, we are not going to understand how managing a pregnant individual is going to differ from a non-pregnant individuals. Cardiovascular system, the cardiac output is going to increase from the beginning of the pregnancy to the term. Maximum cardiac output will happen during the delivery. This is because of increase in both heart rate and the stroke volume. So because of combination of increase in the heart rate and stroke volume, the net result is increase in the cardiac output. And another main contributing factor for increase in the cardiac output is increase in the preload because of volume expansion. Coming to peripheral vascular resistance or systemic vascular resistance, if you see, the systemic vascular resistance will start decreasing from the beginning of the pregnancy and it reaches its minimum by the end of the second trimester. After the second trimester, it starts increasing and by term it almost reaches to pre-pregnant range. So because of this decrease in the systemic vascular resistance, the serial blood pressure or the blood pressure in the pregnancy will start dipping from the beginning of the pregnancy. So it matches the trend of systemic vascular resistance. So we can appreciate the minimum blood pressure by the end of second trimester, and the blood pressure will reaches to its pre-pregnant value by the end of third trimester. So in these first two trimesters, even the mild hypertension or blood pressure slightly on the higher side needs troubleshooting and requires further evaluation. So to summarize, during pregnancy, stroke volume will be increased, heart rate will be increased, systemic vascular resistance will be decreased. So the net result of these physiological changes, increase in the cardiac output and decrease in the blood pressure. So because of these physiological changes, we can describe the circulation in the pregnant population as a hyperdynamic circulation. So when we get to do an echo in a pregnant patient, we can appreciate 4-chamber dilatation. But the right side of the heart dilated more than the left side of the heart. Right atrium, right ventricle will be bigger in size compared to left atrium and left ventricle. Because of this dilatation of chambers, we will be able to appreciate mild regurgitant lesions at mitral valve, tricuspid valve and pulmonary valve. But aortic regurgitation will not be seen in the pregnancy. If you can appreciate aortic regurgitation in the pregnancy, that is not normal, that is pathological, which needs troubleshooting. Coming to ECG, there is no major changes when compared to non-pregnant individual except a bit sinus tachycardia plus or minus axis shift. Coming to respiratory system, there will be significant changes happens in the physiology of the respiratory system, both anatomy and physiology of the respiratory system. The major finding is decrease in the residual volume and increase in the tidal volume. So due to increase in the tidal volume by 40%, the minute ventilation will be increased. So as the demand increases as the gestation progresses, the demand will be increased and tidal volume will be increased and minute ventilation will be increased. But residual volume will be decreased because of upward shift of the diaphragm by 20%. So there will be 20% reduction in the residual volume and 40% increase in the tidal volume and minute ventilation. Total lung capacity and respiratory rate more or less the same. There is no major change except slight decrease in the total lung capacity, which may not be significant. Coming to anatomical changes in the respiratory system, there will be airway edema when the gestational age, as the gestational age progresses to the term, there will be airway edema in the nose, nasopharynx, oropharynx, laryngopharynx, sometimes in the trachea also. So because of this airway edema and airway narrowing, it is expected to have a difficult airway, and because of the decrease in the residual volume and total lung capacity, it's expected to have readily hypoxemic events while intubating such pregnant patients. So because of all these physiological changes, our monitoring threshold will be different. As I told you, there will be increase in the heart rate and increase in the stroke volume, so we can accept slight tachycardia. Slight sinus tachycardia we can accept up to a rate of 90 to 100. Unless it is more than 100, it doesn't need troubleshooting. Coming to blood pressure in first 2 trimesters, in fact by the end of till mid third trimester, we can expect a patient, a pregnant lady, to have lower blood pressure. Because of physiological changes in the respiratory system, the baseline ABG will be different. Because of increase in the minute ventilation, there will be respiratory alkalosis. So we can accept a PaCO2 of 30 to 35 millimeters of the mercury. So if PaCO2 of more than 35 millimeters of the mercury indicates there is respiratory acidosis, which needs troubleshooting. That means there is some problem with the ventilation process. So as a compensation to this respiratory alkalosis, there will be decrease in the bicarbonate level. So the baseline bicarb will be 18 to 23. Unless the bicarb is less than 18, we don't have to bother much. Coming to renal functional test, because of the increase in the cardiac output, there will be increase in the GFR. That means renal blood flow will be increased. Because of the increase in the renal blood flow and increase in the GFR, that results in augmented renal clearance. So the baseline creatinine level will be less. So for a pregnant individual, a creatinine of more than 0.4 will be significant. So that needs troubleshooting, and we need to follow all possible nephroprotective measures. That means kidney protective measures. Coming to liver functional test, there is no major change when compared to non-pregnant individuals. But there will be baseline elevation of alkaline phosphatase, because alkaline phosphatase will also get secreted from the placenta. Coming to coagulation function, pregnancy itself is a prothrombotic condition because of imbalance between the procoagulant and anticoagulant factors, and because of the stasis of the circulation, as IVC will get compressed because of gravid uterus. Coming to positioning, of course, we will follow head-high position for all patients, but in case of the pregnant individual, especially term pregnancy, we should be obsessive about positioning individual in head-up position, because in case of the pregnancy, the gastroesophageal angle will be increased. There will be high chances of the regurgitation and pulmonary aspiration. So unless we maintain this head-high position, high chances of the pulmonary aspiration and other adverse effects can be expected. Another point to remember is we need to place a wedge under the hip so that the weight of the gravid uterus will be removed from the, will be removed from the aorta, because the gravid uterus will cause certain level of the compression on the abdominal aorta, which will decrease in the preload, sometimes may cause hypotension, especially when patient is hypovolemic. So to avoid that, we need to place a wedge under the right or left hip, or if possible, if patient is comfortable, we can place the patient in the lateral position. So head-high position, wedge under the hip. Head-high position is to avoid aspiration, wedge under the hip is to avoid hypotension. Coming to procedures or special precautions while doing procedures, as I told you, there will be significant reduction in the residual volume and total lung capacity. While intubating a patient, the high chances of having hypoxemia, so the pulmonary reserve will be less. So while intubating a pregnant patient, it is mandatory to pre-oxygenate the patient, and we should be prepared by all means to handle the anticipated difficult airway. Radiation, unless it is very much clinically warranted, unless there is a strong indication to get X-ray or CT, we don't have to do we don't have to expose the patient to radiation. If at all patient has to go for either X-ray or CT, we need to cover the belly with lead sheet. Coming to cardiopulmonary resuscitation, here we need to remember that we are handling two lives, mother and the baby. So while CPR is going on, it's our job, or it's your job, to ask the surgeon or gynecologist to deliver the baby then and there itself, so that after delivery of the fetus, due to the delivery of the fetus, there are two benefits. One is baby, there is a high chance of survival of a baby. Second thing is, as the baby is out, there will not be any compression on the IVC or aorta, so the blood, there are high chances of getting return of spontaneous circulation. So the chances of survival of both mother and baby will be increased by doing perimortem cesarean section. Coming to specific disorders to pregnancy: hypertensive disorders, liver disorders, and bleeding disorders. Hypertensive disorders, there will be variable spectrum of diseases starting from gestational hypertension. The hypertension that happens after 20 weeks of gestation age. Once this hypertension associated with organ dysfunction, we can label it as preeclampsia. Once this preeclampsia affecting the central nervous system or causing seizure, we can label it as eclampsia. And chronic hypertension is when blood pressure is higher within 20 weeks of gestational age. And then the last spectrum or last variant of hypertensive disorder is preeclampsia superimposed on the chronic hypertension. We will discuss in detail. We also can classify the hypertension as per the severity of the blood pressure. Hypertension more than 140 of systolic or more than 90 of the diastolic. Otherwise, systolic blood pressure will be when systolic blood pressure increases by 30 millimeters of the mercury from the baseline. Diastolic blood pressure increased by 15 millimeters of the mercury from the baseline. Moderate hypertension is systolic of 141 to 159, diastolic of 91 to 109. Severe, more than 160 systolic, more than 110 diastolic. Hypertensive emergency is nothing but more than 170 systolic or more than 110 diastolic. Apart from this, any hypertension causing organ failure which requires immediate management, we need to consider it as hypertensive emergency. How to manage? If patient into the ICU, we need to consider IV infusions. Labetalol is preferred drug as per doctor's advice, doctor's prescription. We can start the labetalol dose, labetalol infusion. If patient doesn't respond to labetalol, next option is hydrolyzine infusion. But patient comes to the OP, there are many options are available like methyl-dopa, labetalol, hydrolyzine, nifedipine, prazosin, and clonidine tablets. Even in the ICU, we can use labetalol and hydrogen infusion as a bridging therapy, and later on we can switch over to oral therapy. Our targets for blood pressure: systolic blood pressure of 130 to 150, diastolic blood pressure of 80 to 90 millimeters of mercury. This is the way to control hypertension. IV infusion doses: labetalol 20 mg of the bolus over 2 minutes, and we can start with 10 mg per hour and increase to 40 to 80 mg. 10 mg per hour, we can increase up to 20 to 160 mg per hour infusions. Hydrolyzine, we can give a bolus of 10 mg over 3 to 10 minutes. We have to give hydrolyzine bit slower compared to the labetalol infusion. The infusion rate will be 10 to 20 mg per hour. Unlike non-pregnant individual, we need to avoid nitrates in case of the pregnancy, because giving nitrates is deleterious to the baby, deleterious to the fetus. Next spectrum of hypertensive disorder is preeclampsia. hypertension associated with organ dysfunction. It can be increase in the proteinuria, which is we can calculate the protein estimation with the help of protein creatinine ratio, which is more than 30 milligram per millimoles. Increase in the creatinine, and if there is evidence of hemolysis, liver dysfunction, CNS involvement, heart failure, and fetal growth restriction. So if hypertension associated with all these organ dysfunction, we can label it as a preeclampsia apart from having proteinuria. The preeclamptic patients requires immediate admission into the ICU or admission into the hospital if patient is having severe headache, visual disturbance, severe pain in the abdomen, and severe nausea and vomiting. If patient presents with all these symptoms, that patient requires immediate admission into the ICU and immediate control of the blood pressure and other supportive care. If possible, emergency LSCS, emergency cesarean section and delivery of the baby. What is the role of magnesium sulfate? If this preeclamptic patients having CNS involvement, CNS irritability and the seizure, then we can use magnesium sulfate as an anti-seizure drug or anti-epileptic drug as a salvage measure. So the dose of magnesium sulfate is 4 grams as a bolus and 1 gram per hour for 24 hours. We can even say this magnesium sulfate we can give as a salvage measure for super-refractory status epilepticus even in case of non-pregnant individuals. But in case of the pregnancy, there is severe preeclampsia or eclampsia, then we can give magnesium sulfate as a salvage measure. But while infusion is going on, it's our responsibility to monitor the muscle tone, muscle power, and any signs of the respiratory depression. It tend to cause neuromuscular weakness and respiratory failure, and we need to monitor the serial levels of the magnesium in the serum and need to titrate the infusion rate. The second types of diseases, liver disorders in the pregnancy. There are different diseases which are specific to the pregnancy pertaining to the liver. Those diseases are hypertensive gravidarum, intrahepatic cholestasis of the pregnancy, AFLP, acute fatty liver of pregnancy, and HELP syndrome. Among these 4 conditions, AFLP and HELP syndrome will be associated with bad prognosis, and even they require emergency LSCS to save the mother. Other 2 diseases are bit benign, we would be able to manage with conservative measures. We can see hyperemesis gravidarum in first and second trimesters, and patient presents to the doctor with excessive vomitings and weight loss, nutritional deficiencies. Coming to lab parameters, bilirubin expected to rise by 4 times, transaminases expected to rise by only 2 times. Management, antiemetics, pyridoxine, doxylamine, and majorly dietary changes. Few modifications in the diet will help to relieve the patient's symptoms. The second disease is intrahepatic cholestasis of the pregnancy, which we can see in first, second, and third trimester. And presentation will be because of excessive accumulation of the bile acids. There will be pruritus, excessive itching will be there, and there will be diffuse rash because of the itching, and there will be jaundice. Labs wise, bilirubin will be increased around 6 times from the baseline. Transaminase will be increased around 6 times. The major or specific finding to the intrahepatic cholestasis of pregnancy is increase in the bile acid levels. Coming to management, we need to give high dose of bile salts, that is udilin or ursodeoxycholic acid. The third disease, most dangerous disease, is AFLP, acute fatty liver of the pregnancy. We can see this disease in second and third trimester of the pregnancy. Patient comes to the doctor with very vague symptoms like some fatigue, headache, abdominal pain, and mild hypertension. Unless we have high level of suspicion, most of the times we tend to miss the diagnosis of AFLP. Labs will be 6 to 8 times elevation of the bilirubin, 5 to 10 times elevation of the transaminases. The most specular finding or particular finding is hypoglycemic events because of liver dysfunction. Management, it requires immediate delivery of the baby to save the mother. Here, of course, whatever may be the situation, our priority is always a mother. HELP syndrome, we can encounter this disease in the second and third trimester of the pregnancy. The presentation will be hypertension, hemolysis and thrombocytopenia. Bilirubin will be increased, or transaminases will be increased around 10 to 20 times. We can expect to have indirect hyperbilirubinemia because of hemolysis. And other hemolytic signs like increase in the LDH, increase in the cystocytes on the smear, and decrease in the haptoglobin. Management, supportive therapy, of course, delivery is the definitive management. The fourth and last variety of disease is bleed, especially postpartum bleed. Patient comes to ICU after the surgery with severe PV bleed, mainly because of uterine atony or retained placenta or retained tissue inside the uterus, or trauma-induced laceration or injury to the uterus or vagina. Coagulation failure, coagulation dysfunction because of variety of diseases. It can be only because of the bleeding consumption coagulopathy or liver dysfunction, or pre-existing coagulopathy can be triggered with delivery on the pregnancy. If there is uterine atonic uterus, if anybody works in the OT, especially obstetric OT and in the labor room, you must have seen that they'll start IV oxytocin and methergine, other prostaglandins. Those are called pharmacological measures. First we need to try with pharmacological measures like IV oxytocin, methergine and prostaglandins, and then we can step up our tie-off management to the invasive measures like peel-inch suturing, tamponade with the help of Foley's catheter or balloon. And third tie-off management is surgical management like uterine artery ligation, or sometimes in extreme scenarios patient may require hysterectomy to control the bleed and to save the life. The second cause is tissue or retained tissue in the uterus, which warrants immediate removal or immediate clearance of those retained products by whatever means. Trauma, it requires repair, and coagulation dysfunction, patient requires replacement of the coagulation factors like cryoprecipitate, FFP and the platelets. Once the fibrinogen level reaches an acceptable range, and once we are confident enough that coagulation factors have been repleted, we may consider factor 7A replacement if all other conservative measures or all other regular measures have failed. So all these scenarios are not very uncommon. We actually must have seen, like all of you must have seen, many patients who have admitted into the ICU with major bleeding, and the management will be differed as per the etiology. So to summarize, the monitoring and management of a pregnant patient is majorly different from managing a non-pregnant individuals. It's majorly because of significant physiological changes. Because of these physiological changes, our monitoring threshold will be varied, like we can accept a little bit of sinus tachycardia and respiratory alkalosis, and if you do echo there, because of hyperdynamic circulation, chambers will be dilated, some amount of the regurgitant lesions will be there, and coming to labs, baseline creatinine will be less. A creatinine of more than 0.4 indicates there is acute kidney injury, we need to troubleshoot. And positioning, patient should be always in head high position. If it is term pregnancy, we need to keep a wedge under the hip to avoid hypotension, especially in case of hypovolemia. And in case of hypertensive disorders of the pregnancy, we should put all efforts to control the blood pressure to bring back to the acceptable range with the help of IV labetalol infusions. Among liver disorders of the pregnancy, AFLP and HELP associated with bad prognosis, which warrants immediate delivery. Among these two, AFLP has been associated with very bad prognosis. Bleed, as I explained, there will be tiers of management. First tier will be pharmacological, second tier invasive, and third tier will be surgical management. Fetal monitoring, in spite of cause of admission, whatever may be the measures you are taking, on the back of the mind we should remember that baby is there, we need whatever measures we take, that also should protect the baby along with the mother. And of course, if situation comes to choose only one life, mother is the priority, because a baby without mother means we are not doing justice to either of them. Thank you very much for this opportunity. I thank again Chandana ma'am for the opportunity and the invitation. Thank you, and good luck. Have a good day.